Hello, hello, hello. We are ready to go. All right. Greetings, everybody. Well, nearly all. If anybody didn't get, I forgot to bring them with me, that answer sheet for the take-home practical. Like I'll have them. I'll put them at a little desk in front of my office. Those answer sheets. So I had a handful of them left, and I just sort of hustled out. I forgot a couple of things and had to run around and get them. Nevertheless, we are on. We're as the song says, we're getting there near the end. So all you have is kidneys, male and female reproductive, and see ya. Yes, ma'am.
What chapters are the practical ones?
The one that.
The takeout.
Good question. I don't know. I don't know. Whatever. I think central nervous system, a very small amount of peripheral nervous system, heart, and blood vessels. Okay. And then the last one will be respiratory, digestive, urinary, and reflux. Okay. And basically, again, another labeling exercise that surely we'll be doing at the very end of, when that second week we come back, that type of thing. So, the final is the final. I think it's the Wednesday of finals week. And, I think we're the Wednesday of finals week. We're in that 1:30 nugget for our class,
Yeah.
as I recall. I think I checked it the other day. That's that's it. And unfortunately, I'll see too many of you next term. Oh, you can't have everything. You know. So I look forward to, and we get an extra week. We don't have to come back until the day after MLK Day, which is cool. I hope to be somewhere warm and sunny, at least for some of that time. Visiting my daughter-in-law and the two kids, because exactly 1 minute ago, a particular destroyer just shipped out of Norfolk and is heading in an easterly direction. Destination unknown, but you can guess. Goodbye to him for a couple of months. Easy. Not good. Not good. Which means you give us a very good excuse to go down and visit the grandkids and spend all that. Yes, ma'am.
So, take-home quiz that you email us, that's the practical?
That is your take-home practical, yes.
Okay. So, Monday.
Yeah, I like to have it by Monday. Because that's our last meeting before turkey time. Or it could be turkey tetrazzini, which we were looking at recipes. It's like turkey with pasta. Turkey a la king. Or my personal favorite, after Thanksgiving, open-faced turkey sandwiches with grill. What? Oh, sometimes, yeah. We don't want me making the bread. Don't start. You're toying with my emotions. That's an emerald line every time we talk about certain foods. Don't go there. You're killing me. All right. Moving on. So the kidneys, which we all hopefully use appropriately. And we're going to talk about the anatomy, but inevitably physiology is part of it. So we're going to look, it has a very interesting anatomy. And you might recall me at the very end of last time talking about how unique that anatomical aspect is. So even though these are all the functions that you can see demonstrated up here, we really aren't going to touch a whole lot of them. Basically, if anything, this is what we're probably looking at more about water bodies than anything else. At least dovetails into the anatomy, and in doing so, plays a role with making sure your total osmolarity remains relatively stable. With some exceptions, concentrations of ions, certainly at the base. The major report is probably what we'll look at a little bit, is also about how it deals with waste and toxins a little bit here. And we really talk more about erythropoietin, and this is fast backwards. Okay, everybody. Erythropoietin has nothing to do with blood pressure, but a lot to do with RBC production. Erythropoietin is the agent that stimulates your bone marrow to make more red blood cells. Where renin, in this case, is just one end, is the one that plays a pivotal role in the renin-angiotensin-aldosterone mechanism, which we're going to touch on several times, particularly so in physiology. So that's backwards. It's another one of those interesting areas, and these are some of the endocrine functions as well as those agents, which are endocrine agents, also of activating vitamin D, because remember the skin plays a role in that, and it can even carry out gluconeogenesis, and I won't go through all that Dr. Hillwood loves to do. You know, glycolysis and gluconeogenesis, all those enzymes she's so fond of. So, and the last part of this is really where our focus point is the kidneys. There's a minimal amount, albeit very important anatomy, that deals with effectively, once stuff leaves the kidney by way of the ureters. The ureters are just tubes that the urine, once it's already processed, goes out. Okay? And those tubes are stored temporarily in a bladder and eventually excreted by way of the urethra. So this, nowadays, we used to call this upper and lower tract. Now we just call this the urinary tract. And the kidneys used to be the quote-unquote upper tract. Now we just say the kidneys. So it's the language has changed a little bit. So there's a thankfully relatively small amount of anatomy in the urinary tract. Not a lot to say. Very important, but not a lot to say about it. And so here's the typical diagram. Again, a diagram undoubtedly you'll see on a practical. And you can see the most notable thing. I commented on it before. How do you know renal artery? Renal artery question. Right. It's wide, disproportionately so. As you go farther away down the aorta, the blood vessels are supposed to arteries. Okay. Not here. They get wider. That's because this relatively small but extraordinarily important piece of human anatomy is nothing really more than a high pressure filter. It's all about, and the kidneys are very sensitive. If there's not enough pressure, they shut down. If there's a blockage, they shut down. If somebody goes into shock, they shut down. If there's an infection, they shut down. I always make the, it's like the little kid in the playground that doesn't get their way. They shut down. Okay. That's what the kidney does. I'm taking my bowl and I'm going home. Get the F out of here. But get the flock out of here, right? The shepherd is there. So that's the idea. So it's disproportionately wide. And as you're going to see when we get into the physiology, the pressure is comparatively high. So the width of the vessels really play, because it has to do a lot. Because the whole idea of this pressure filter is by carrying the blood effectively, as you will see, to the exterior portion, the outer borders of the kidney, which we call the cortex, it's able to continue to have enough pressure to effectively filter the blood. And it doesn't just do so it periodically. If you figure you have 5 liters of blood on average, that's filtered approximately 36 times a day. It creates what's called 180 liters of filtrate. The filtrate is everything in your blood except for the formed elements, white cells, red cells, platelets, and proteins. They're too big to get through. Everything else is filtrate, and that's all the plasma and all the stuff dissolved in the plasma other than those aforementioned things. Okay? It creates 180 liters of that, and then in doing so, it reclaims approximately 99% of that. So if the end product for 180, if you divide it by, multiply it by 0.01 roughly, you get 1.8 liters, and that's roughly what we urinate out every day, 1.5 to 2 liters of urine on average, depending on your degree of hydration activity, blah, 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 blah. All that stuff. So they're busy constantly and extraordinarily important, okay? A tremendous amount, perhaps even more so than your digestive tract, of your typical blood flow right now, kidneys, yes, sir. Say again. Oh, you only need about, it's redundancy. You only need about 25% of one kidney. We have about 8 times as much kidney parenchyma. And that's this recurrent theme that I talk about in respiratory, it's a recurrent theme I talk about in digestive. We've got a ton of spare parts. It's like your own spare parts bank. And it's the good news, bad news. The good news is you got kidney you can donate. And even if the donated kidney afterwards you get sick, some kind of disease, as long as you have one kidney functions out of four, you can still go perfectly normal. Okay? The trouble is once you get below that, you're done. You're done. So that's the trouble. You see it in respiratory, somebody who has to magically go on oxygen when they can breathe fine, and all of a sudden, all those backup systems. That's the horrible thing about it. Your heart can do that, and all of a sudden, it's a false sense of security, and it's why a lot of people take, myself included, for many years, their health for granted. And to some extent, most of us still do. We usually don't address something until typically it's a 5 alarm fire. I've always found people either are obsessed with it or obsessed with not with it. Either they really, I'll be fine, don't worry about it. And then all of a sudden, something bad happens, they start coughing up blood, and the next thing you know, they've got lung cancer. Or by the other token, is people who just, every time they get a hangnail, they go to the doctor. You better put me on medicine. I could die tomorrow. And I think it's interesting. I think, once as you get older, you lose, some people lose it sooner because of what happens to them. You have a certain sense of immortality. And then once you're confronted by your mortality, you become more cognizant of it. It doesn't necessarily mean you do something with it. In general, women, I feel, this is my opinion, because of the reproductive aspect, are much more cognizant of reproductive health. And I talk about this a bit when we do repro, that women are much more focused about reproductive health and regular reproductive checks or checkups, however they are, whoever administers them. And forgive me for saying it this way, guys don't care as long as the equipment works. But it's true. I mean, I'm not trying to be flip or rude. I'm just telling you that's what gets a guy's attention. Okay. Yeah, it just does. I'm not surprising you, I would think. I'm not casting any aspersions. I'm just telling you this is realistic about it. Yes, sir.
Why don't you run out of plasma if plasma's in the filtrate?
Beg your pardon?
Why don't you run out of plasma? Plasma's in the filtrate.
If plasma is in the because it's constantly being given back to you, almost immediately. So what happens is, as soon as you start to give up, think of it, it comes out in a trickle and it's reclaimed almost simultaneously. And so it's a relatively rapid process to filter its way through the kidney. So as you're producing this filtrate, once it goes into a series of funnels, once it goes into this, you'll see the anatomy short, it goes into this first funnel. It immediately goes into something called proximal convoluted tubule. You reclaim 67% of the filtrate by the way. So think of it as a continuous process. The difference would be if someone starts to bleed out, then you have a significant problem because then they can't reproduce fast enough. But this, as long as it's working properly, if it doesn't, then obviously reclamation. And then you start to get these irregularities. So it's like a lot of, as long as it's working fine, we generally don't notice it. What they do now, and I think I showed you didn't I show you my blood tests? Maybe not. Okay, I'll do that. Now what they do is they estimate, typically when you get what's called a BMP, basic metabolic panel, which is pretty much a standard thing that your doctor will have you do once a year or twice a year. They will look at your electrolytes and other chemical factors, and they will be able to, they have a formula to set up a number to estimate what's called your GFR, which is glomerular filtration rate. It's an estimate on how well your kidneys are working or not. And that's sort of the clue. If that number starts to go down past where it shouldn't be, that's kind of like a heads up, you better get looking at this. So I'll show it to you. Mine's been my only bad number is my red count, stuff like that. But that's been that way for a long time. So there's the setup. You have the kidneys probably depicted here larger than they are just for demonstration purposes. The one on the right sits a tad lower because the liver's very heavy and large and sitting on it, pushing it down. Other than that, they're about the same. The important area here where everything enters and exits, the renal artery exits, the renal veins, renal artery enters, I beg your pardon, the renal veins exit, the ureter exit, this is the hilus. And as you might have guessed, it's kidney shaped. I thought that would get it. I must be getting older. Nobody laughs anymore. Hilum, it's like the hilum is like the notch of the kidney. Think of, and we have one in the lung. There's a hilar area, and it's just an anatomical term they typically use where there's an area where things transit in and transit out. Like in the liver, it's got the porta hepatis, but effectively that's the hilar area where things, sort of a busy point for things going in and going out. Nose. So it's retroperitoneal. It's for, again, things that are firmly attached to something are designed not to move, and it's protected, and it's even protected overlying, as you will see shortly, by the lower ribs. And the ribs aren't horizontal as much as the lower ribs particularly go much more down. So there's a certain amount of the kidney that is exposed. Right side a little bit lower. The adrenal or suprarenal glands, whatever you want to call them, sit on top. Adrenal was originally from adjacent to the renal area. Convex and then concave. The concave has the hilar area, and then there's a little space they call the sinus. And everything kind of goes in and out, as you can see. So you can see the coverage that's here. There's a little area down below that may be slightly exposed. In the old days when boxing was popular, they didn't allow you to do a thing called a kidney punch, which was like punching from the side almost around the back, because you could really hurt somebody. So that was, and he used to call it a rabbit punch. And so that was the type of thing that in a boxing match, somebody would get warned and then maybe penalized. For you boxing fans that aren't ultimate fighting and kickboxing and cage fighting. I mentioned that to you. I went to the very first fight in the new Madison Square Garden in 1967 with my dad and my buddy. Joe Frazier against Buster Mathis. Emil Griffith against Nino Benvenuti, 2 championship fights. Go ahead.
Is this like where your spleen is?
Your spleen's there. So spleen is more accessible because it's soft in front of it. The kidneys are protected a little bit more. And the spleen is not. So the spleen, somebody makes a tackle with a helmet in the gut, you can rupture spleen. Ruptured spleens are something you really have to be on the lookout for, comparatively speaking. So it's surrounded by fascia, that's denser connective tissue. It has just like the heart, it has a certain amount of fat that's there. And again, fat by that is more protective than anything else. It's not as though somebody, you accumulate fat there when someone's overweight or anything like that. From a culinary standpoint, it's called cull fat, C-U-L-L. So they'll take the cull fat from pigs because pork fat rules. Sorry, I know, I used to be kosher. And why not? And they'd wrap things in that because it imparted flavor and moisture. That's a French cooking technique. They also cook inside a bladder, pig's bladder, called envesi. So you got to watch more cooking shows. You knew that. Okay. And so it's got a capsule that's really thick, and we'll dissect it. For fun, next time we can dissect the kidney this weekend. Maybe a lung. Yes, ma'am. I don't know. Short answer. Assuming they're both healthy, I do not know.
I wasn't sure if, as the liver, they would take that one.
That might make the access harder. Makes me. If you were, I don't know. It's merely speculation on from my limited knowledge of that. I never participated in one. In any, we had a small inner city hospital. The most sophisticated things that we did, they would do bypass, not of the heart, but like arterial bypasses in the leg for somebody with bad circulation. We put an artificial joint in. That's about anything that was, heavy duty. We farmed out that kind of stuff. That would go to University of Pennsylvania or Hahnemann. We were fairly close to in Pittsburgh. That Hahnemann is now under the umbrella, I think, of Drexel, absorbed all of those from a medical school perspective. But Hahnemann used to be a medical school, and so you have Jefferson, U of P, Drexel, as being a big medical school. PCOM, it's over on Siegel Line Avenue. I spent 6 years in Philadelphia. I know the layout of the land. So many cheesesteaks, so little time. No pat steaks in the South? Oh, come on. It's Philadelphia. They throw snowballs at Santa. If you think Steeler fans are rabid, these guys are not. They're mean. So the capsule is kind of dense. So here's the retroperitoneal. Here's the location. Okay. Thoracic cage, fat, lower part, more susceptible. Kinds of things that we can see that. Diagnostic criteria, blood in the urine, as you might guess. Okay, big distinction. When you see red blood in the urine, it's typically after someone has been in an accident or a fall or a sporting event. That's when you start thinking about that. Okay. Blood in the urine from somebody, when it's blood that's been there from from a urinary tract infection, the blood has already started to deteriorate, so it discolors the urine. When you see red blood in somebody without that, like me, then the first 63 things you think of are bladder cancer. So that if somebody's peeing red, all of a sudden you're going and it's bright red and there's no history of trauma. Bladder cancer, and then still think about bladder cancer. Particularly with an idiot who smoked 2 packs of cigarettes a day for 40 years. Just saying. I'm not so think as you dumb I am sometimes. So the renal artery that's why it's an important unit. Especially vulnerable, as you can see. Lacerations can be torn. Part of that is that's kind of why lap seat belts. This is another reason spinal cord injuries, kidney injuries fell into that. When we used to do, this may surprise you, you didn't always have to have a seat belt. I know, shocking. It's like my
industry actually pushed it on us.
Pardon me?
It took 10 years for them to be implemented. They were invented because the auto industry pushed against it.
Oh, they didn't want it.
Yeah.
They didn't want it. It was restrained. Oh, it's. If you go smoking and the same, all these types of commercials for things like that. Oh my gosh, it's crazy. It's crazy. All of that kind of stuff. I mean, I tell the students now when I tell you about when we didn't always wear gloves and gowns in emergency room. I'm working in emergency room for 77 to 79. Do you think it's like on TV? Oh, you all have glass. Heck, no. None of that stuff. You put it on if you had to do something. Somebody comes in and bleeds, boom, put your hand on it. Stop. So hematuria is the name for that, and then depending on the color. And yeah, obviously surgical treatment. So the exterior of any organ, just like a bone, cortex, the inner area is the medulla. So we use the same terminology now, and you're going to see when we talk about the glomerulus, which we probably will get close to today, or even get to today, is the principal structural and functional unit. That's where the filtrate is created. The glomeruli, of which there's about 1 million in each kidney, about 85% of them are in the cortex. About 15% are on the border. They're called juxtamedullary glomeruli versus cortical glomeruli, and they do different things. They do the same thing, but they emphasize different aspects of it. And then when you get into the medulla, it's either passageways for the blood vessels coming in and out, or those large pyramidal structures that you will see shortly, whose bases point to the exterior cortically and whose tips or apexes point more centrally toward the hilar area. That is really where the urine is effectively, if you will, dripping down and being collected. That's kind of where the processing, a lot of the processing, and particularly what you're going to see, what we call loops, occur. So the base of the pyramids face the cortex, the papilla or tip internally or centrally. The tissue in between the roughly 7 or 8 pyramidal structures are called columns. And they are really part of cortical tissue, and they're the passageway for the blood vessels. And when we look at the pyramid and the surrounding cortical tissue, we refer to that as a lobe. So there's a lot of anatomical terms. In fact, I'd rather have you know about the pyramid and the tip and the apex, and what the court then test you on what's a lobe. And effectively, it's a collecting of a series of funnels. At the tip of each of these pyramids is an opening that's funnel shaped. And think of urine dripping into it. These are small. Several of them, 2 or 3, come together into yet a larger funnel. So they're called minor calyces and major calyces. Singular is calyx. So several minor calyces form a major calyx. There are generally 2 or 3 major calyces, and those calyces too all feed into a common large funnel, and that is referred to as the renal pelvis. So you should know the flow chart from pyramid to minor to major to pelvis, and the stem of that, the opening of the funnel is the pelvis. The stem of that funnel is the ureter. And at that point, you make the transition from kidney to urinary tract as it exits. Here, the real thing, so the pyramid's obviously in a dissected out specimen. It's a little hard, but you can see the little sort of funnel-like openings. Here's one, here's another, and they form into a major calyx, another major calyx, another major calyx. Here's renal pelvis, here's the start of the ureter. Here, going inward into that same area, you have the blood vessels. A little easier to see this way. Renal artery comes in, renal veins go out. Okay, so they're in that same area, but the arteries and the veins, effectively, the arteries sort of dive deeply, if you will, underneath and begin to traverse, as you can see by little hints of the blood vessels through these columns. Each of these is a pyramid. It's almost got like a linear, sort of like a pleated border, if you want, a pleated superficial appearance. When you slice open, which you guys will do, a kidney, you'll see that. And you're welcome to take them home if you're like into steak and kidney pie. So our British friends, they have, chips and crisps, fries and potato chips. And they eat beans with breakfast. What? It doesn't appeal to me. But they are really good with peas. Oh. They smash the peas. Oh, those are good. And they drink a great deal of beer. For you beverage fans. So when you infect the pelvis or the calyces, they call it, and I don't care about this, and pyelonephritis. Most of the time when you hear about somebody with a kidney infection, they talk about pyelonephritis. The whole thing is involved. Most of the time, and I say this all the time, I say it with digestive, I'll say it with reproductive. Ultimately, it's a plumbing problem. When something gets stuck, everything backs up. That's the problem with urinary tract infections, which are much more common in women than in men, and it's anatomically oriented. If it is not treated satisfactorily, it ascends. And in women, obviously, you can get also affect reproductive as well as urinary structures. In man, it's obviously a little bit of a longer journey, but still is fraught with the same kinds of problems. As it backs up and gets either into the kidney, the functioning organ, rather than just a passageway, or the testes, the functioning organ, rather than just a passageway, big trouble. Okay? So the same idea. So most of the time, typically these infections anatomically, and I don't think you covered this in micro, but maybe you did, we deal a lot with, it's really fecal related bacteria. It's like, we call them, the fancy name, I don't know if you got this in lecture or in lab, they're called coliforms. Coliform, because about 70% are E. coli, so they're gram-negative rods that behave similarly to E. coli. Proteus, which you work with in the lab, would be one of those things. Klebsiella, conceivably, though that's typically not from that. There's a gram-positive called Staphylococcus saprophyticus, Just saying. And they, again, all these abscesses, terrible. You need strong antibiotics. I'll give you the clinical note. The most common medications we take for urinary tract infections, particularly so in women, are called combination sulfa drugs. They come from, again, whether you cover this in micro or not, I do, called trimethoprim and sulfamethoxazole. They are sulfa-based drugs that work on the folic acid pathway, which we don't have. We have to ingest folic acid. That's why they're efficient. Bactrim and Septra are the trade names. They're very easy to use. They're very convenient. They are super cheap. They've been around forever. They're now a first-line treatment for community-acquired MRSA and have been so for a long time. That's if somebody gets MRSA community-acquired, not in a hospital, they put them on Bactrim or Septra. Good news. Bad news, does not work on the kidney. Urinary tract levels are fine. To get inside the kidney, you need a bigger gun. So usually you're looking at Keflex or something strong in that area, cephalosporin, typically. So this is the anatomical, the most fascinating part is the blood flow. So this is what it does. It cleanses the blood and adjusts it. So the arteries deliver every minute 1/4, roughly, let's say to 5 liters, about 1,200 milliliters of your cardiac output to the kidneys each minute. They renal, they go up the lobes, they segment and they go up into the lobes, interlobar. They arch over the pyramids. Arcuate is the name we give to arteries that arch. Then you have little straight cortical radiation or straight, and then what you see after that is they will form these capillary beds called glomeruli where the filtration crosses. And they sort of back their way back down and sort of reverses. We don't see segmental veins. It's purely sympathetic nerves. We get to that next term. The kidney is one of those unique areas that doesn't, not like the heart where the sympathetic makes it go faster and the parasympathetic slows it down. When it comes to kidney, it's all sympathetic because it's all about blood flow. So blood vessels are only sympathetic. I didn't know if you got that yet or not, but we will get to that when we do the autonomic nervous system, which is really important. So here it is. Okay? And so here they are branching up, and you see they do straight ones that go up and they radiate, and at first they arch over, then they come up and radiate, and they make these little points, which are hard to see from the illustration here, and those all open into glomeruli. Most of them are cortical. Some are relatively close to the cortical medullary border, and those are equally important. This is what I pointed out a little bit last time at the very end, and I know at the end of it, everybody's just ready to leave, so you don't listen and I move all this. I know it was a long time, 50 years ago, I was sitting where you were sitting. Even 20 years ago. 2001, I was teaching at Roche, and was also taking courses because I wanted to need a job. It was tough getting a college job. So I was only part-timing it. So I was going to be a high school. How long have I been left as a high school science teacher? I'm guessing the over and under 10 seconds, 12 before I said something too snarky or dropped an F-bomb. 20 seconds. 30 seconds? No, it would have lasted that long.
What?
No, in high school.
For what?
Me.
Oh, what?
Because I'd say something inappropriate.
You? No way.
Stop being nice to me.
I'm sorry. You're in charge of my grades.
What?
You're in charge of my grades. I have to be nice to you.
Yeah, you know.
Okay.
I'd rather have people be real.
All right.
So, and you keep it real.
Okay. I got these guys. Don't worry.
So, here it is. This is the big deal. When those radiate out, they form an arteriole, very small, that leads into a capillary bed. You'll notice the red color gives it away. It's the only capillary bed we got where arterial blood goes in and arterial blood goes out. Because what's making the blood leave the arterioles and start processing in the capillaries has nothing to do with ATP. It's all about the pressure. It's a high pressure filter. So when your blood pressure drops, that's when one of the things happens when you go into shock. Your heart starts to race, your kidneys shut down. So it's kind of like in your garden. You've got a lot of people take real good care and they have watering systems and you have that, just bring that thing out, the hose, the garden hose, and you attach to it. If you just put a little water, trickle of water, kind of just, it doesn't do anything. The minute you bring it up high enough, it starts to, you know, pressure allows, right? You have one of those? You know what I'm talking about? Like that sprinkler unit? Maybe you have the golf course has the ones that kind of do this. It won't do that unless it's got pressure. So the pressure drives the bus to the efferent arteriole, and you don't lose any of the oxygen or the nutrients that are there. It's not until it starts its merry journey into where you're going to see the structures that basically the blood continues on and leads to a capillary bed. But at that point, the blood is also feeding this series of tubes called the proximal convoluted tubule, the nephron loop, and the distal convoluted tubule to permit the reclamation project of the filtrate of the urine. It brings back all the stuff that's good, gets rid of all the stuff that's bad. It basically does three different chores, as you will see. It does what's called tubular reabsorption, bringing back the good stuff, tubular secretion, getting rid of the bad stuff, okay? And it all comes from glomerular filtration. Down the road, in a smaller percentage, about 15% of these loops, we have the additional process of concentrating the urine, which is equally as important. And you will see that. And then it's basically, it goes through these two capillary beds. The ones that are in the cortex are called peritubular capillaries because all the capillaries are around the tubes. It's mostly reclaiming it or secreting it. And the vasa recta, long straight veins, are draped over these what are called long loops of Henle, capital Henle is a proper name. And those long loops are where we concentrate urine. And that is the most complicated area when we get to physiology, because it has something called the countercurrent multiplier and the countercurrent exchanger. And to this very day, after I've explained this to students for 20 years, I still don't understand it. And it starts forming in infancy. It starts forming when you're born. And you all know that because how often do you have to change a baby? A lot. Okay? And so it takes a long time before they can become, if you will, continent with regard to urine. And all of that is the development over time of this countercurrent system, which is how we concentrate the urine. Just to give you a little physiological nut. Physiology is really going to be hard. I hope you're get up, get your game up. They say on Dancing with the Stars, let's get ready to rumba. You don't say that? You ever watch Michael Buffer in boxing? Let's get ready to rumble. This is let's get ready to rumba. Okay, nephrons. These are the big players. Okay, about 1 million per kidney, as I said. They have two parts, the blood vessel part, which are called corpuscles. Erythrocyte affects, we used to call it red blood cell or red corpuscle. So they derive the name from that. And the tubular system that collects. And as we're going right back to funnels. So the two parts of the corpuscle are the glomerular area, this tuft of capillaries. In its simple squamous epithelium, if you remember and go back to when we looked at capillaries, the liver has the big sinusoidal ones. Most everywhere else has the basically called continuous because it doesn't look like there's any gaps. Fenestrated means windows, and it's like, think of it as a big filter. These little holes, and they can adjust the size of the hole somewhat. So they're very porous. And so it efficiently filtrates, and so the plasma-derived fluid we call filtrate is what eventually gets processed after it's reclaimed and processed, bring back the good, get rid of the bad to create urine. So that's the big, so if effectively a high pressure filter. So That's why pressure has to be so controlled. If there's not enough, it doesn't work at all. If there's too much, okay, what happens if you take a coffee filter and you put it under a big flow of water? Oh, I'll just rinse this filter out. Boom, tears. Think of it that way. So pressure is really important. So it's surrounded. Here's this nodule of capillaries. I look because they always access the wrong stuff. You don't say like saran wrap. They say clean film, aluminium. We say while, they say whilst. Pardon?
They say
Petrol. Okay. The underground. Yeah. The subway. That's the subway. The lift. That's the elevator.
Probably.
Yeah.
Trousers.
What?
Trousers.
Trousers. Pants. Yeah, but they probably don't speak Yinzer. You know, like my wife does. Look what's on the wall, a pitcher. That holds water in it or other beverages. Pitcher. Just saying. Who knew? So surrounding this bundle of capillaries is a funnel that surrounds it and creates a certain amount of suction pressure. It's famously called Bowman's capsule. So it's cup-shaped, it's hollow, and the cup effectively is the funnel, and the stem, as you will see, becomes famously the proximal convoluted tube. Why is it convoluted? It twists and turns. It has like a lot of things. The glomerular area has a lining layer of simple squamous and a visceral layer that clings to the capillaries, and you sort of open and close them a little bit by way of these foot processes. Little slits between the processes can adjust flow, and we do this all the time so we don't get too much or not enough. Pressure gets low, create more flow. And you're going to see when we look at the artery itself, the arterioles, it's wider going in. We call that the afferent or incoming arteriole. It's narrower going out. We call that the efferent arteriole. And we can adjust those. Okay, if we're retaining too much fluid, we create more filtrate. The more filtrate, the more urine. So you're going to see when we get into physiology, most of what we do in our kidneys, and that's why we don't notice it, is automatic. It sort of auto adjusts. So most of the way the kidney works, you don't have to control it. So this is what it looks like on the capsule, simple squamous. Here you can see along the basement membrane, little fenestrations are in here. They'll show you the illustration. Okay. The tubules aren't that terribly long. This is slightly more than an inch. Okay. They have epithelial cells. As they get more function, they change. The hallmark epithelia of the proximal and distal convoluted tubules is simple columnar, a simple cuboid. You're going to see proximal is busier. They have proportionally more mitochondria and more microvilli. There's a lot more spitting stuff out and pulling stuff in. Less so in the distal convoluted tubule. Proximal, closest to the corpuscle or to the glomerulus, a loop, and a distal. And the distal convoluted tubules, you will see, many of them drain into one structure called the collecting duct. And that series of collecting ducts kind of create this sort of rippled appearance that you will see in the pyramids. So, cuboidal cells, microvilli, brush border, surface area, big mitochondria, they're busy. This is where the energy, this is why the arterial blood now, when it finally goes through or surrounds this area, becomes venous blood, because you're feeding these mitochondria constantly to perform the exchange. They'll even bring in stuff you're going to secrete later to create gradients. So you'll reclaim stuff that you're going to spit out down the road to make sure you have a satisfactory concentration gradient. Because like most things, concentration gradient kind of drives the bus. So just like the proton motive force, What do? We expend energy to make more protons on one side of the mitochondria than the other, so it can go through, the ATP synthase molecule. It's kind of spin the turbine like they always show you, right? We do that all the time. You do all that stuff with the NADHs and the FADHs, right? See, that's how it works. Just saying. See, you should be excited about this. This is where we put this picture back together that you've been studying for the last 3 years. All the mitochondria, all the microvilli. The loop used to be called the loop of Henle, and I just say nephron loop, because Henle lost out. U-shaped, as a descending limb that's thin, and ascending limb that's thick. You're going to see the descending limb down the road, water moves. Ascending limb, water doesn't move. So it goes from simple squamous to cuboidal. I'll show you the pictures. And the distal convoluted tubule back to cuboidal cells, not as many microvilli. It's doing more secreting than absorbing. And less mitochondria, less microvilli. And this is what it looks like microscopically. This is the capsule is this space. This is the lining of the capsule on the wall. Here is this nest, of you will, this bundle of epithelial cells that have come together to form the glomerulus. These are the tubules. You can see the round nuclei, simple cuboidal. So on a histology exam, which some of you will go through, if you're going on to graduate or medical school levels, they'll show you a picture like this. It's slam dunk for kids. Nothing else in the body looks like this. Because nothing else has that. And different kinds of cells that are there, either they have, it depends on what they do. This is more function, whether it's water and sodium, acid-base balance, and then everything, and I'm just about done, leads into these collecting ducts. And the collecting ducts, again, make that striped appearance of the pyramids. And they all kind of come together at the bottom and make up those minor calyces. So I'll just show you, this is just, we'll end and start with this. They're not so far apart. This is for demonstrations. Here's a single glomerulus. Here, the funnel cap, the Bowman's capsule, convoluted tubule, proximal loop, thin, thicker, distal convoluted tubule, all the way back, multiple entries to a collecting duct. And you'll see that they're really close together. But they're showing you this for demo. And this is another illustration that you'll see. Thank you all. We'll see everybody Friday. Yeah, I'm not taking this Friday off. Sorry. I know.